Hi, Dr. Hagedorn.
Very nice to see you today.
Okay. Welcome to our conference. We're super glad you're here. Can you tell us all, like, what kind of doctor you are and where you work and who you see?
Of course, thanks for having me. I am currently at the University of Washington, which is located in Seattle, Washington. And my training, for medical school, I went to Stanford University in California. I finished my urology residency there as well. And then I did specialized training at the University of Washington for reconstructive trauma urology. And that's
So,
where I see my patients who have incontinence after prostate cancer treatments.
so the idea of trauma is actually interesting and probably worth just starting our conversation, because if a guy wasn't experiencing a traumatic event as a consequence of prostate cancer treatment, you and I wouldn't be talking, outside of hello and, how you doing? But I
Right.
mean, many people characterize urinary incontinence as an aspect or a side effect from prostate cancer or prostate cancer treatment. But you could go like 3 levels deeper and perhaps darker and say it's not just a side effect, it's an actual traumatic event. I mean, does that make
That's
sense to you?
correct. That makes sense to me, since any surgery is can be a traumatic event to the body, and it's basically removal of the prostate. And we even see incontinence from a pelvic fracture. That's maybe more of a traumatic event from a car accidents. And but surgery in itself is disrupts anatomy and can be traumatic to the body for sure.
Yeah, and it also adds another sort of nice thing in the sense that, like, I mean, prostate cancer affects guys in their third age, so to speak, just as we get older. I'm part of that group now. So, I mean, and, urinary incontinence to some degree affects all of us, assuming we live to 120, certainly getting up in the middle of the night once, twice, 20 times, perhaps a drip, a leak kind of thing. Prostate cancer treatment, whether it's surgery or radiation, is has more impact than just the course of life urinary incontinence. Is that
That
right?
that's correct. That's correct. And right after prostate surgery, I would say that almost 100% of men are incontinent, and you have to regain that incontinence. So we see patients all the time after prostate cancer treatments. With the radiation, the onset is a little more slow. The incontinence happens a little, further down the line. But yeah, you're right.
So
Incontinence can is more prominent in that patient population for sure.
what's the difference between guys who come into your office who don't have prostate cancer and are just concerned about urinary incontinence, or a fracture, as an instigator of urinary incontinence, and prostate cancer guys? What are they actually complaining about, or telling you about their life experience?
Good question. There's a big differential diagnosis if someone comes in with incontinence. It can have it's multifactorial, can be multifactorial, or have very many causes. So, for example, diabetes, spinal cord injury, Parkinson's disease, infection of the urinary tract can lead to incontinence. Also, benign prostatic hypertrophy, where the prostate can get really large over time and the patient doesn't empty well, and then it always has a full bladder and then has incontinence. So usually those patients, we have to find out what exactly the reason is. And patients with prostate cancer treatments, they usually have a good control of urine before the treatment, and then have incontinence afterwards. So we can, usually we can blame the treatment for the incontinence.
Do you have, we have some slides that you could show that actually
Yeah,
describe visually what's going on and why it's going on and what we could do about it. Can you start sharing your
yeah,
screen now?
I'll be happy to share that.
Okay. Is there a way you can make it a full screen?
Yeah.
Yeah. This is the hard part of screen sharing.
There we go.
Yeah,
I think
excellent.
you can see that.
Yeah.
Great. I'm going to start with anatomy because that's very important, I think, to understand why patients have incontinence. So this you see here is a pelvic anatomy, and please interrupt me and ask questions as we go through these slides. I hope you can see my pointer here, but this is the prostate right here, located close to the rectum, right underneath the bladder, and the urethra goes right through that prostate, and then through the penis and out comes the urine here, the tip of the penis. The urinary sphincter, that's the muscle sphincter that the patient has control over, is located right below the prostate in the pelvic floor.
And can you describe the seminal vesicle ducts and such?
Yes, of course. And the seminal vesicles are located right behind the bladder, close to the prostate as well. And they're usually also removed during the prostatectomy operation for cancer. So during a prostatectomy, the prostate is removed right here from the bladder neck, and also here right at the apex. This is the apex of the prostate, right here close to the sphincter. And the surgeons are very careful not to go beyond that sphincter and keep that sphincter intact. And so my next slide shows you here that before the prostate surgery, you have the prostate in place, and the sphincter you can see here that you have control over is orange. And after the surgery, the bladder now is connected to the urethra to let the urine still go through its normal path, but the prostate is no longer here. So the patient really depends now on the external sphincter. In a man, there's we say there's three continence mechanisms. It's the bladder neck, the prostate, and then the external sphincter. And during prostate cancer surgery, the prostate is removed, so the patient now is reliant only on the external sphincter after surgery.
And could you describe the difference in the way the sphincter behaves and the bladder neck behaves?
Very good. So the bladder neck is not voluntary. So the patient doesn't have control over that continence mechanism. The external sphincter can be squeezed, and the patient can usually find that muscle with trying to stop the urine stream in the middle of the stream. So that's how you can tell that you are activating the right muscle. The bladder neck has an underlying intrinsic sphincter, but the patient is not aware of that.
Right, which is an important thing for guys to know, because you're now like truly in control of your bladder by virtue of your brain and your sphincter and all the muscles that interact with all that have to sort of learn how to work in concert together in a way that they hadn't prior to surgery or radiation.
Sure. Yeah, because of the underlying continence mechanisms that you didn't have to control. That's correct. Yes. So we have different types of incontinence that we just briefly touched on earlier, but stress urinary incontinence is really the incontinence that we just described, is when someone has had the prostate removed, is now reliant on the sphincter, and the sphincter might not be strong enough anymore to be able to hold the urine inside the bladder when there's stress or pressure forced on the bladder. So with coughing, sneezing, or getting up out of the chair. Some patients only have a few drops of leakage, and then when they exercise or go running or lift weights, that's when they really feel their incontinence the most. And that's called stress urinary incontinence. And then what you see more with diabetes, spinal cord injury, strokes, but also with radiation for prostate cancer treatment is that overactive bladder. And that's more of an urge where the bladder squeezes without the patient having control over that. And the sphincter might be intact, but the bladder squeezes so hard that the urine comes out. And some patients have that mixed incontinence. So usually I assess patients before any kind of intervention for urinary incontinence and what category they fall into for better counseling. My evaluation always includes a cystoscopy. The patient is in clinic. There's a lidocaine jelly that gets injected into the urethra. The patient is usually laying down on a stretcher, and that lidocaine in the urethra helps with comfort. That usually should stay about 10 minutes to have effect. And then we look, the patient can see it on the screen, and I have a camera attached to that cystoscope that you see there. That's the size of a catheter, and that goes through the urethra. And we can then assess the urethra as well as the area where the bladder has been reconnected to the urethra. It's called the vesico-urethral junction or vesico-urethral anastomosis after prostatectomy. That's what I want to see to make sure that there's no contracture or stricture in that area.
So of the patients that you have on your table, like, percentage wise, more or less, like how many are okay with this? How many say, give me some more lidocaine or knock me out? And what percentage do you think actually watch and enjoy the show?
Very good question. I think that most of the patients, maybe 98% of patients tolerate this very well without any pre-medication. Some patients are anxious and would like, some medication prior for anxiety, but the procedure itself, it doesn't take very long, maybe 5 minutes, 5 to 10 minutes. And the patient, usually enjoys the show if they can see the screen and can see their anatomy. It's very important. I also have them squeeze their sphincter to see if there's some residual um, uh, contraction that we can see together. So that's important to show the patient as well. And it's very well tolerated procedure. I don't have anyone that doesn't. Very rarely we have to take patients to the operating room, but it's really a clinic procedure that doesn't need any anesthesia.
Mhm.
And then we said earlier that there is stress urine incontinence. If I assess the patient and they have a clear urethra, there's no strictures, there's no bladder neck contracture or any vesico-urethral anastomotic stricture, then we usually can go ahead and talk about incontinence procedures. Some patients I'm concerned about that the bladder might not be ideal for an incontinence procedure. And those patients might have underlying poorly controlled diabetes. They have the urge incontinence, the overactivity, where they can't hold urine more than 30 minutes to an hour. They might have an underlying bladder dysfunction, and radiation can really affect the bladder as well. So patients who have had prostate treatment with either just radiation or prostatectomy plus radiation, I want to make sure that their bladder capacity and compliance is good and they can hold urine after I put in a device for them. And so what I recommend undergoing is that urodynamic testing in clinic. And you can see here, it's a little busy, that slide, but you can see here the patient's usually awake. That procedure takes about 40 minutes. The patient's awake, they get a very small catheter, much smaller than that cystoscope that I just showed, but a very small catheter placed in here. It's in female anatomy, but same for male anatomy, placed into the bladder, into the rectum, and then monitors also to monitor the pelvic floor muscles. And so that will show us then how much urine can, or how much contrast in that case can the bladder hold. Does the bladder compliance, has that changed from radiation? That means, does the bladder have really high pressures with filling, which is concerning, because if you have an outlet procedure where you then have the bladder hold a lot of urine, the pressures in the bladder can go up and then affect the kidney function. So we want to be, do we want to make sure with this test that the bladder can actually hold enough urine at low pressures? And then also we can discover if someone has overactive bladder, where the bladder would squeeze, the patient would feel urgency during the exam, and then usually can't control that urge and then has leakage. And so all of that can be assessed with that urodynamic study. It's not for everybody, but for patients who I'm concerned about the bladder compliance capacity, especially after radiation. And then the first step, I always tell patients, try some Kegel exercises or a referral to physiotherapy. And usually the surgeons who perform prostatectomies have talked about that with our patients in advance. And as I said, usually I tell my patients after prostatectomy, there's very, very high chance you are incontinent, and you can speed up the recovery with doing the Kegel exercises. And you want to find that right muscle, and that would be trying to stop the urine stream during urination. The recommendation is to try those Kegel exercises 3 times a day, 10 repetitions, where you hold the muscle and squeeze it for about 3 seconds and then let it go, and then repeat that 10 times. And the therapist, if you get referred to physiotherapy, the patients should see someone who is experienced with pelvic floor exercises. Not all physiotherapists offer that. So it's important to find out before you go see a physiotherapist. And that's usually really, really helpful right after prostatectomy for stress urinary incontinence. It wouldn't be helpful for overactive bladder symptoms. These Kegel exercises really are to help the sphincter get stronger after surgery.
Is it something that patients should do prior to treatment?
It can hurt to get the muscles really strong before treatment, then it's probably stronger after.
Mm-hmm.
And then when should the patient have intervention? Some patients might experience this incontinence right after surgery, and you should really give it some time to improve on its own. The Kegel exercises can really speed that along. And I would definitely encourage everyone to wait for at least 1 year, up to 2 years, even after a prostatectomy, or once your symptoms have plateaued, to then seek treatment for incontinence.
What about how long after radiation therapy?
Very good question. Radiation therapy, I'm hesitant to operate too close to finishing the radiation treatment, because radiation still can have an effect on continence even further down in the future. So I would say that for radiation, I would wait for 9 months, a year after the therapy has ended. And then how do we decide what to offer? Is it a male sling? And I'm going to show you pictures on that. Or is it the artificial urinary sphincter? And it really depends on the level of incontinence. As you can see here on the left, there's mild incontinence, and then on the right, severe incontinence. And mild is defined to using 1 to 2 pads per day. I think it's important. Some patients change their pad with every time they go to the bathroom. So that's not what that pad per day use calculates. It's more how a pad needs to be completely soaked to count as a pad. So if you change your pad every time you go to the bathroom, but it's only a little moist, then that doesn't count. So sometimes if the patient can't, know how many pads they use, or change it very frequently because they are not comfortable having moisture in the pad, or even feeling that it's somewhat full, then what we can do is a pad weight, where the patient brings in all the pads they have, and they collect it for 24 hours, and we can measure that. And then there's a cutoff on when we say a male sling is still considered, or an artificial sphincter is needed because of the severity of the incontinence. Mm-hmm. And there are definitely high-risk patients, which I do more counseling for. And those are the patients who have had prior radiation, bladder neck contractures, or the vesico-urethral anastomotic strictures that we talked about before. Then anyone who has had urethral surgery or any urethral stricture repair in the past. And then prior failed artificial sphincters or erosion or infections. Those patients are at higher risk of having failure with the devices that we place. Patient selection for a sling, the optimal candidates are the post-prostatectomy incontinence patients with mild or moderate incontinence, 1 to 3 pads a day, or a pad weight that's less than 400 grams. So we have to measure that, and we can do that in clinic. And then the ones that have residual sphincter function, which we can see on cystoscopy when the patient is able to squeeze the sphincter at the time we look inside the urethra. So those are the ideal patients for the sling. And here I have a picture on how that sling works. It actually doesn't completely occlude the urethra or push the urethra together. It more is a backward pull of the bulbar segment, which is, you can see here, this is the bulbar area that's surrounding the urethra, and that is being pulled back and supports the sphincter and the membranous urethra, which is right in that area, and then can control or help with continence. That surgery is done as a day surgery. The patient might stay overnight or might go home the same day. Sometimes we leave a catheter in overnight that's then taken out. And the patient usually is in what we call lithotomy position during the operation, where the legs are up in stirrups. And the procedure takes about an hour.
Right. And you could do that with an epidural as well, couldn't you?
That's exactly right. Yes, we can do it with epidural anesthesia instead of a general anesthetic.
Let's sort of dig into this
Yeah.
little thing here. So on the second circle to the right, I mean, where you're describing how it's pulled back, what is it attached to that? What do you attach it to pull it back?
Very good. So it's going through the transopter foramen, which is the part of the pelvic bones. I didn't include that picture because that's more something we see in surgery, but it's basically going through the two big openings in the pelvic bone. And the mesh that is placed, it has little hooks on it, so it doesn't move once it's placed.
Right. And does the patient feel any of that after they get a chance to heal?
Very good question. So one of the complications of sling placement can be chronic pain in that area from pelvic nerves that run there. It's not very common, but definitely something that the patient should know about before undergoing sling surgery, that in some patients it can lead to pelvic pain.
And for those guys, can it be removed and the pain goes away?
Very good question. If the nerves are not, permanently damaged, I would think that if the sling gets released, that then the pain hopefully can get better.
Right, but for a small percentage, it's a permanent or at least
Yep.
multi-year
Could be
situation.
permanent.
Yeah. So the idea is squeeze a little bit, but it's still up to the guy's brain and body to work the sphincter and get it to close off completely.
That's exactly right. So the patients who do best with the sling surgery still have some underlying sphincter function that they're in control of. Yes.
Right. So, sort of, I mean, I could hear like I have like 1,000 guys watching this virtually, and I could hear them all shouting in the back of my head, like, well, why do a sling? Couldn't you just wrap something around the urethra and sort of screw it a little tighter, or, give me replicate the action of the sling in a less sophisticated, more common sense sort of way?
Right. And that's when the artificial sphincter comes in to play, where
Which
that is
is,
really
yeah.
a wrap around the urethra.
And that must be your next slide.
That's right. So sling outcomes, I just wanted to bring that up. Everyone improves. Even if you have really severe stress incontinence, you will have some improvement by having that sling pull on that membranous or bulbar urethra. But then, really it's patient selection because you don't want to just improvement from, 6 pads to 3 pads. The outcome, a cure rate is really 1 pad or less a day, and that's achieved at 50 to 65% of the time of sling placement. I think even higher if you choose the candidates for that surgery well. And then failures of that sling can be treated with artificial sphincter. They're kind of in a different area of the urethra. So even if someone has had a sling placed, there's still a room to place an artificial sphincter. And now we're coming to that. So the artificial urinary sphincter is really a cuff that gets placed around the urethra and works almost like a muscle on it. So it's the inflatable cuff is right here, and we place it around the urethra. Then you have a pump in the scrotum, and then there is a pressure regulating balloon that's placed It can be placed right behind the rectus muscle or right in front of the bladder behind the pubic bone. And this is all concealed, so from the outside, you don't see any of this. And the patient then feels for this pump. You pump the fluid from the cuff that's occluding the urethra is then pushed through the tubing, from the tubing up into the pressure regulating balloon, and then the cuff is open. That cuff stays open for about 30 seconds, and the patient then urinates during that time. It can even be pushed again if that doesn't allow the bladder to empty completely. And then after about 30 seconds, because of that pressure in that balloon being high, it then pushes the fluid back down, fills up the pump again, and then fills up the cuff. And the cuff then exerts its pressure again around the urethra to keep you continent. And any questions for me on that?
I mean, the sort of the 1,000 guys behind me are asking, why not just go straight to that?
Good question. Good question. You have to, the sling, you don't need any operation, right? You don't have to pump anything. You don't have anything that you need to be worried about for hand function. There is more tubing. There's more things that could potentially fail. The sling is a mesh that usually once it's in place, it stays in place, and it's has less worry. You have to be less worried about it breaking.
Well, does this break or last forever?
Very good question. So about a third of patients will need some kind of revision in the first 5 years of this device being placed. Usually the company says the device can last for about 10 years. And then we see failures. I've seen patients who've had these artificial sphincters placed many years ago. So it can last much longer, but their failures are expected at around 10 years.
Yeah. And this hand control aspect of it, I mean, it's really not as difficult as the slide may imply. I mean, it's literally just a quick little 3-finger, I guess, 2-finger kind of way to do it.
Yeah. Initially, I tell my patients to hold the tubing at the top and then, stabilize the pump. But eventually the patients will be very comfortable doing this with one hand as well. Yeah.
And the times that the times that you use it are no different than the times you would normally go to the bathroom. If you feel like you gotta go, you just go. And it's just another thing you do prior to urinating.
Yeah. It becomes second nature. You're right.
Yeah. So failure rates. I mean, why would this fail someone?
Very, very. So there is device failures, and that could be because the tubing breaks. There can be some leakage of the fluid that we put in to make this all work. There can be a mechanical problem with the pump. So the device itself can break very rarely, but it can. And then we have also issues with, of course, infection. So infection is a big deal. So if a device gets infected, we usually can't save it. If antibiotics don't help right away, then we have to explant the entire device. What can also happen is that the urethra right under that cuff doesn't do well. And when I say doesn't do well, the cuff can erode into the urethra, and then there's an opening between the urine and the device, and then the device can get infected. So that's called a urethral erosion, and that's when we need to explant the device. What also can happen is because of constant pressure on the urethra, the tissues around the urethra can atrophy, and we call it subcuff atrophy, where now the sphincter or the cuff that was placed now can't exert as much pressure anymore to keep you continent. And that's when patients notice over time to have more and more leakage again. And then we might have to go through to a smaller cuff or place the cuff in a different location. Or, yeah.
No, go ahead.
Or we can place it transcorporally, and I have another picture on that as well.
Okay. Let's see that one.
Yeah. So this is the AUS as it comes in the packaging. I just wanted to show that it has the yellow is called inhibizode. It's an antibiotic coating that the device has on part of it. And then here's the transcorporal placement. This is actually my last slide. The transcorporal cuff placement, if you can see, this is the a coronal view of a penis. So the penis has erectile tissue that's important for erections. That has two compartments, and then the urethra is underneath. And so when I say transcorporal approach, and we do that to avoid any urethral dissection in some patients who've maybe had an artificial sphincter before, who've had urethral surgery before, that dissection might be difficult. And so what we can do, or in patients, for example, who've had a 4-centimeter cuff, and now we need to move a little more distal where the urethra might be smaller, and we want to avoid placing a smaller cuff. And I can talk about that briefly in a little bit, but we want to place a bigger cuff. Then we go transcorporal. So we include some of that corporal tissue. We make incisions in the corpora on both sides, right next to the urethra. And then we close those compartments again, so it doesn't affect your erectile function. But we go through that and then incorporate that corporal tissue under our cuff placement. It hasn't shown to prevent erosion, but you can place a larger cuff. And we know from many studies that a cuff that's 3.5 centimeters, which is the smallest that the company makes, has a really high risk of erosion. So we want to stay away from using a 3.5 centimeter cuff. And that's when we make the decision to, in the operating room, usually to go transcorporal or to stay around the urethra.
And, actually, this is a good slide to remind people. The penis actually it's not just what you see, it's also in your body,
Right.
Yeah. Actually, why don't you tell us, how much, sort of like an iceberg in some respects, how much of the penis extends isn't the right word, but is below the pelvic bone, let's say.
Quite a bit. So I would say 2/3 are exposed and a third is behind your mons or skin, and that goes down all the way to the pubic bone. And so where we operate to place this is, and I'm gonna just go back again, we make an incision behind the scrotum and go really close to where the urethra then meets the pelvic floor and is sitting under the pelvic bone. So we can move along here by placing the cuff here a little further out, but not too much. At some point the scrotum is in the way, and then we don't place it around the penile urethra.
Does the surgery affect those who have restored their erectile functioning after surgery?
No, the erectile nerves, they do not run along the bulbar urethra where we place the sphincter. Also, if we do a transcorporal approach, I would say that the risk of impotence after that is very, very low.
Okay. And what percentage of your guys, or of not just your patients, but in general, want this pulled out after, let's say, a month or two?
Very good question. The success rate and the patient satisfaction is really high after artificial sphincter placement. Patients usually say, "I wish I had done this before. Wish I would have undergone the surgery earlier." It really restores the quality of life of patients after prostate treatment.
Very good. Let's hold this slide for a second. So
Yeah.
put on your inventor cap on. If you don't have one, I'll lend you one, but you're now a medical device inventor. Like, what improvement on this, or what do you imagine might actually just be a whole different way to do this, but a better way to do this?
Very good question. Very good question. So, potentially having something propel the urine outside of the body quicker Some patients need to, pump a few times in a row to get the urine expelled, but it would be kind of neat to have a little turbine in there that would propel the urine forward. And the other thing would be maybe having a adjustment, which I've heard might be in the works, an adjustment of the pressure around the urethra, where you could adjust that remotely. Because we place the artificial sphincters around the urethra and we measure the distance it needs to travel. So, the 3.5 centimeter cuff I told you about, the 4 centimeter, 5 centimeter cuffs. So that's measured, but we don't have a way to adjust the pressure it exerts on the urethra afterwards. We put the pressure regulating balloon in. There's 2 types of it. One that has a lower pressure, one has a higher pressure. Sometimes we try to use a lower pressure for patients who've had radiation where the erosion risk is somewhat higher, but it would be very neat to have a pressure regulating device that could do this remotely.
Yeah, and here we are, sort of like a 19th century hydraulic solution. One could imagine, it's like a pumping station in London or something. One could imagine, a cell phone based solution where you have the cuff. It has a server attached to it. It's regulated by an app on your cell phone. It's recharged by an electronic magnetic device, the way cell phones are now recharged in a discrete and unattached way. I mean, there are opportunities for doing this in more interesting ways, I think.
For example, if you could turn up the pressure it exerts during exercise, but then if you lay down, as you can imagine, gravity, your bladder could hold a little more urine before you actually leak. During the nighttime, it could relax the pressure around the urethra. That would be neat. Yeah.
Does oral sex affect the effectiveness of this?
No. So the act of having oral sex, the incontinence mechanism the continence mechanism of the artificial sphincter should hold tight even with that. So if you had some leakage during exercise, and that can be very detrimental to patients from a quality of life standpoint. They say during sexual activity I leak, and the artificial sphincter, if that holds well during exercise and getting up out of the chair, it also should keep you continent during sexual activity.
Sure. Well, thank you for showing us your slides. Could you return to your,
of course, happy
to your face? Yeah. Great. Hi. So let's talk about like urine. Like, are there different kinds of urine?
Oh, urine? Sure. There's different kinds of urine. Usually as a urologist, we think right away about kidney stones and the composition of urine. I think that if you talk about incontinence, there's, infected urine, there is darker urine, lighter urine. It all depends on your hydration. There's urine with blood in it. There's very many kinds of urine. Yes.
Yeah, but can a guy sort of regulate or improve his outcomes around just having a successful sling kind of experience if he could alter the composition of his urine?
Not that I am aware of. A lot of patients who come to me with incontinence have stopped hydrating themselves, because the more urine you make, the more incontinent you are. So I think there's definitely a large patient population who has concentrated urine that's very has a smell to it and is malodorous sometimes because it's so concentrated and yellow, and that's from dehydration. So I think that when my patients come to me and say that they have incontinence, they're trying to not drink a lot, especially at nighttime and during the day, I see how they try to control the incontinence with that. And hopefully with an incontinence procedure, then they can go back to hydrating themselves. But there's nothing you can do as far as not drinking or eating something differently from how well a sling will work.
Yeah, or Kegels for that matter. I mean, the idea of being dehydrated, I mean, there's like a paradoxical effect. You think like less liquid, less coming out, but at the same time, you're sort of, I just lost the word, but you're debilitating or drying out your sphincter muscle, or your body's just not at its optimal as
Right.
when it's hydrated, well hydrated, appropriately hydrated. So, and then as you mentioned, you concentrate urine and it becomes like stinky, you know?
Exactly.
Yeah, and life becomes not pleasant.
Yes,
Uh,
for sure. And
yeah,
you can smell the underwear, and it's all because of the, urine itself. When it dries, it has a smell, but the more concentrated it is, it has a very strong smell.
yeah. So stay hydrated is really
Stay
even for
hydrated,
those. Yeah.
exactly.
Yeah. What are some of the, so talk about the quality of life experience that your patients tell you directly when they're talking to you.
Yeah. So I can tell you, after the continence procedures, and that's why I am in the field I am, because I most of the time I have very happy patients after the procedures. I remember a quote from a patient that, "You brought my life back," because they are bound to home. They don't want to go outside because they don't know where the next restroom is. They have to wear a pad, and it's like we just say, smelly and really debilitating, and they have to have all the supplies with them at all times. So they worry about leaking into the pants if the pad doesn't catch the urine. So it's very, very impactful um, in the quality of life, and decreases the quality of life quite a bit. And so after the surgeries, then usually we have the patients really go back and are really happy that they underwent the surgery.
Yeah.
And after the sphincters fails, many of them can't wait to get a new sphincter placed.
Oh, that's interesting. Do they have to wait a long period between failure and the new surgery?
Very good question. So if there's a device failure, no. If the device has a failure and we can pinpoint where it is within the first 3 years, we can even just replace that part, because it comes in three parts. There's the cuff part, the pump part, and the regulating balloon part. So if we know where the problem lies, we can just replace that part. And that's
And
in the first 3 years. After that, we replace the whole part, but we don't have to, wait. We can just remove and replace the same.
with 100%, or even the best surgeon's going to have close to that. If patients with urinary incontinence, most people would wonder, why not just do this implant while you're under getting your prostate removed?
Very good question, because I think that the incontinence rate after prostatectomy is there for everyone initially, but we don't know exactly who will recover their function and who won't recover their function. So we don't want to place it in everybody, because it has its own risks as well.
Yeah. Does anyone ever die from having this in?
Very good question.
Somebody does, but
Yes.
yeah.
So, surgical complications are always there, where, we counsel patients on blood clots and cardiac complications, anesthesia complications during the surgery. But aside from that, the most life-threatening part is infection. If the patient gets a really bad infection of that device, it can lead to blood infection and then sepsis, and that can be life-threatening. Very, very rare. And usually if there's infection, the patient will know about that, because there will be redness on the skin, there might be some blood in the urine, there might be, it depends where the infection is around the device, but we usually put them on strong antibiotics and try to get the device removed. And that's when we wait a little bit before we then consider replacing one.
Yeah.
It's also with erosion. So if there was a cuff erosion into the urethra, we want to make sure the urethra heals well and doesn't have a stricture before we place a new one.
Yeah, and cuff erosion and just trauma to the urethra, it's not something that's really discussed, I think, at all,
Right.
really. Yeah. So good that we're talking about it today.
Mhm.
It's not a deal killer, but it's significant and worthy of a conversation with the urologist.
Yes.
The Oh, and just this aside, if you have an artificial urinary sphincter or even a sling, does that prohibit a future erectile dysfunction implant squeezing device?
No, it doesn't. So the device you are talking about is the
Yeah,
inflatable penile prosthetic,
yeah, yeah.
and we can place it even after having an artificial sphincter. Yeah.
So a
Some
guy could
people
have
get
lots
both
of,
placed at the same time. Some
yeah,
people stagger it, and the most of my patients, they are really, they say, you know, sexual function is not on my top priority. I want to get continent first, and then we'll discuss the implant for the potency.
yeah. Which sort actually it leads into the next and perhaps final thing for today. The idea of I mean, there are a large number of guys that are single in the United States and worldwide. I mean, the United States, I think it's like 48 or 49% in 2019, men over age 50 lived alone, you know,
Mhm.
which is staggering and almost unbelievable, but there it is. You know, I mean, even if it's wrong by 5%, that's still a lot of men.
Right.
For men who uh, have relationships with, you know, either another man or another woman and come into your office together, do and try to compare. If you don't have many who have erectile dysfunction issues, like try to imagine, is the conversation around urinary incontinence more devastating or creating more of a devastating impact or less than erectile dysfunction?
I would say incontinence impacts the quality of life on a day-to-day basis much more than erectile dysfunction after surgery. And the patients and their partners, if they come to clinic, they say, let's get that continence first under control before we focus on the sexual function. Yeah,
Yeah. No,
it's really
urinary
impactful.
incontinence is like I mean, we know about it. It's unfortunately minimized as an outcome. Um, and it shouldn't be. I mean, in our insanely large support group network, we see it in almost everyone post surgery,
Right.
and you know, and many guys post radiation. You know, but the impact on enjoying life is significant, and it's just not discussed and rarely addressed as having a solution. You know, usually it's sort of blame the victim, do some more Kegels for a year or two.
Right. And with the Kegels, you know, I tell my patients, give it a 6 months, but if they haven't really worked, I think that you should get evaluated.
Yeah. And
Yeah.
finally, is there a disparity between younger guys and older guys as far as the successful outcomes of any of these?
Good question. You know, the sphincter, or the sling, as well as the artificial urinary sphincter, I would say there's no age cutoff or any worry I would have in someone older versus younger for getting the procedures and also having success with them.
Great. Well, thank you for a very interesting discussion, and thank you for taking good care of your patients. Thank you for being part of our community,
Yes, thanks for having me.
yeah, and welcome to the conference.
Great.
Okay.
Bye-bye.